coronaviruses, which have recently caused severe disease in humans, include SARS-CoV-1 and MERS-CoV. Those are important because in this time where we have a novel virus that we don't necessarily know every characteristic of or every particular aspect of it, we can kind of look to those previous coronaviruses that had human pathogenic potential and get some information from those and kind of inform our decisions. In the 21st century, we've seen 6 emerging coronaviruses that have caused major disease, not all of those in human, some of those in swine, but this is a family of viruses that has the potential to cross species and makes that jump. And so we know that this family of viruses are often referred to as those possessing pandemic potential. And so this is really, I won't say it's not a surprise to anybody, but you know, we expect this from this family of viruses. We believe that there has been some accelerated cross-species movement due to changes in global ecology and human expansion into habitats that weren't previously inhabited by humans, making a little more contact possible and maybe potential for crossover events. SARS-CoV-2, the disease that it causes presents with a wide range of symptoms, varying from very mild, almost unnoticeable, to quite severe. And this list seems to change every day, but currently symptoms tend to appear 2 to 14 days after exposure, and most common symptoms are cough, shortness of breath or difficulty breathing, fever, chills, muscle pain, sore throat, and a new loss of taste or smell. We have also seen reports of gastrointestinal symptoms and other symptoms that are still evolving. It is a novel virus, so that means we get new information every day, which tends to make risk assessment and determination of biosafety levels and handling practices a little tricky. We're all kind of in information overload over in the biosafety office as we try to take in new publications and new information that come out on a regular basis. So we are working to give you the best information and the best recommendations that we can at any given time. The information on viral shedding, infectious dose, stability of viable viral particles on surfaces, and the expected viral load in different patient sample types continue to change as we get more information. We do, at this point, know that transmission is primarily person-to-person via respiratory droplet. There is some potential for fomite transmission through contact with contaminated surfaces. For these reasons, the most important factors in laboratory work with this material are decontamination of surfaces and containment of the specimens themselves. I won't be talking today a lot about person-to-person transmission. That's a different talk. We're just talking about exposure to the specimens today. Exposure to your coworkers, that's another story, another day. Agent-specific risk factors that are used for risk assessment are based on what current published data that we have, and this increases every day, and we kind of refine our recommendations based on that. We did have a very rare instance of thinking that one experiment that was proposed to us very early on could be safely conducted in our facilities, and with some additional information coming out, we revised that recommendation. So please be cognizant of the fact that we're working through a lot of new information all the time. I wanted to point out, as we talk about laboratory work with these patient specimens, in the SARS-CoV-1 outbreak in 2003 and 2004, there were 4 documented instances of laboratory-acquired infections that we are aware of and were quite serious. They were attributed to poor understanding of transmission and handling at the time, and some due to lack of adequate safety procedures that were based on that poor understanding. So I really today want to stress that our office is working to expedite your work, and we know that we want to move forward as quickly as possible in research related to the COVID-19 outbreak that we're currently in. At the same time, we want to avoid mistakes that were made in the SARS-CoV-1 outbreak related to lab exposures to specimens and activities. SARS-CoV-2 is currently characterized as a risk group 3 infectious microorganism. So basically what that means is that it is associated with serious or lethal human disease for which preventive or therapeutic interventions may or may not be available. Typically, we talk about risk group 3 as high individual risk but low community risk. We could probably debate that one on this one, but at this time, it is in the risk group 3 category. That is also where CoV-1 and MERS-CoV are, so it makes sense to put this particular virus in that category. Now, that being said, typically the risk group of an agent corresponds to the containment or biosafety level. So there's 4 risk groups and 4 biosafety levels. And most often you would work with a risk group 3 agent in a biosafety level 3 lab. That being said, there are certain caveats that would allow some limited experimental procedures to be conducted in a biosafety level 2 lab. And that's mainly what we're going to talk about today. So if you're working directly with the SARS-CoV-2 virus, that requires a BSL-3 containment facility. And I know a lot of people on here already know this because you've talked to me directly about it, but UK does not currently have a BSL-3 containment facility where this work could be done. So what we have done is, based on risk assessment, there are limited experimental procedures, usually utilizing COVID-19 positive patient samples, that can be conducted at a containment level, which we refer to in biosafety as BSL-2+ or BSL-2 enhanced. So basically what that means is that is a kind of hybrid containment level. It utilizes your existing BSL-2 facility and incorporates certain work practices and procedures that are typically characteristic of work in a biosafety level 3. So today we're going to really talk about what those procedures are, what we're adding to your laboratory so that we feel comfortable working with these positive patient specimens in your BSL-2 lab. So at UK, we typically require that all work with human source materials in a research lab be treated as potentially infectious. We have not been presented with any testing protocol that results in a human patient specimen that's free of all potential pathogens. You may have samples from patients that you know are screened for certain pathogens, but we cannot screen humans for all potential pathogens, especially when new ones pop up. So we always treat all human source materials as potentially infectious. So work practices and facilities with those materials require good standard microbiological practices to prevent contact with material. These are things that are pretty basic, good laboratory practices. We don't eat and drink in the lab. We don't take materials from the lab home. We wash our hands. We do decontaminate surfaces. We decontaminate waste. We don't mouth pipette. Even though I've been told it works really well, we don't do that anymore. But what we know is that when we have a patient specimen that is positive for COVID-19 or any other transmissible disease, it's really prudent to go ahead and heighten our containment practices just a little bit. And in this case, particularly because we know that SARS-CoV-2 is spread via respiratory droplet. And so it's important to contain any potential aerosols that would be generated in the laboratory. So we like to look at the sample type from the patient because different patient specimen types may have a different impact on the risk assessment that we do. They may impact certain portions of the experimental protocol. We assess relative risk for viral presence and viral load in patient specimens based upon data from previous coronaviruses and also on what fairly limited amount of information that is already published on SARS-CoV-2. We know from SARS-CoV-1 and MERS-CoV that viral presence is very strong in nasal specimens and throat swabs. It's also kind of a little variant in what other body fluids it's predominant in. For SARS-CoV-2, we have some published data on patient specimens that we would expect to be positive for the virus. And we have some data on what the expected viral load in those different types of specimens are. I'm not going to go into this too much, and I can give out access to these slides if you'd like to see these references. But what's important, the point that I'm making by putting up that data is that different specimen types, one thing that we're requiring, and I will talk more about as we go on, all COVID-19 positive patient specimens are required to be handled in a biosafety cabinet. And we would like them to be handled in the biosafety cabinet until they can be properly inactivated. And so one of the assessments that we have to do when we're presented with an experimental procedure with these patient specimens is to evaluate the inactivation methodology. So viral load, specimen type, predicted presence of virus in that specimen type really plays a lot into how we evaluate that. So techniques that would result in a reduction in viral load in a patient specimen may need to be adapted based on anticipated viral load. For example, if you're using a time and temperature dependent heat inactivation protocol to reduce viral load, it may be different for a serum sample versus a sputum sample, because we know that you're just going to find more virus in sputum than you are in serum. And so that's one of those things that we will evaluate as we look at your proposed protocol to use these patient specimens. So when looking at the types of experimental procedures that will be conducted with the specimens as part of our risk assessment, we have some guidance that is pretty well accepted throughout the biosafety community as to what types of experimental procedures should continue to be done at BSL-3 and what could be done at lower containment levels. So some of the experimental procedures that would require strict BSL-3 containment are any type of virus isolation or propagation, any recovery of viral agent from specimens. So that it even includes if you're filtering specimens to recover virus. Any functional assays, including plaque assays, culturing patient specimens in cell-based assays, screening of antivirals, any genetic modification of virus, or any cell sorting that would involve intact virus. And then, of course, any work that would potentially involve animals and SARS-CoV-2 must be conducted in an ABSL-3 facility. Again, reiterating, we don't have these facilities at UK and so are not currently approving any work of this type. Experimental procedures that can be moved down to this BSL-2 plus, BSL-2 enhanced containment level that we spoke about are processing or preparation of specimens, nucleic acid extractions, performing diagnostic tests as long as they don't involve viral propagation, the heat and chemical inactivation of specimens, and anything that you may want to do that isn't specifically listed in this presentation. I would encourage you to get a hold of me and we can talk about it individually, because while we can't allow any procedures that have the potential to allow for viral propagation, even if that's not the express intent of why you're doing that procedure, if that's a potential, we can't allow that. But there might be other types of experimental procedures that we haven't presented that would be appropriate. Once you have, we've got an inactivation method that we feel comfortable with, and you have inactivated your specimens, you can move to standard BSL-2 containment for these types of activities: staining and analysis of fixed smears, examination and processing of fixed or inactivated tissues, molecular analysis of extracted nucleic acid preparations, final packaging, using inactivated specimens, those type of things. So one of the things that I have seen the most as proposed work for these patient specimens is conducting different types of ELISAs. And what we recommend for that, of course, is that patient specimens that are positive are handled in the biosafety cabinet until they're inactivated and then can be placed in the assay. And then the assay can be conducted on the bench in the lab as it normally would be. As you can imagine, especially with a high throughput aspect, doing ELISAs in a biosafety cabinet isn't very functional. But again, we cannot have material that hasn't been inactivated in the open laboratory. So working with COVID-19 patient specimens, at UK, we're going to be working with these positive patient specimens in our standard BSL-2 facilities. And so some of the features that are associated with the BSL-2 facility, I highlight some of these because some of these are things that you need to make sure that your lab has before you start working and that you continue to do while you're working. All BSL-2 facilities have to have doors that are self-closing or have locks in accordance with institutional policies. Basically, you have to be able to restrict access to personnel who are aware of the hazards of what you're working with and know the safety procedures that are specific to being in that laboratory. You must have a hand washing sink. Preferably, this is located near the exit door to remind everyone to wash their hands before they leave the lab. And paper towels and soap should always be available. All lab surfaces need to be easily cleaned and decontaminated, making sure that you don't have any fabric covered furniture or anything like that. Strict adherence to standard microbiological practices, more than anything that consists of not eating, drinking, doing any of those type of things in the lab, and remembering to decontaminate your work areas. BSL-2 facilities should have ventilation that provides negative airflow relative to the corridor. So that means that the lab is actually bringing air in from the corridor toward the lab, and the air should not be recirculated to other facility areas. You should have a certified biological safety cabinet available for use in your BSL-2 facility, and any potential exposure incidents or injuries or anything that occurs in that laboratory needs to be reported immediately through our standard practices for that. Now, when we're working with these COVID-19 positive patient specimens, we're going to add the plus or the enhance to our BSL-2 facility, and the enhancements we're going to borrow from BSL-3 really boil down to one major one. At BSL-3, there is no bench work. At BSL-3, we work inside a biosafety cabinet at all times. So that is the caveat that we're adding to our BSL-2 facilities for these positive patient specimens. Patient specimens will be worked with in a certified biosafety cabinet or their primary containment device, which we'll talk about, until an effective inactivation step has been completed. I would also say, and I'll reiterate this later, if you have a current IBC approval for work with human source material, this enhancement is the main difference. We do have a lot of people who work with human source material and they conduct certain activities on the bench with other PPE and other precautions in place. And so this will be the difference in working with these specimens. So when we talk about primary containment devices, mainly we do talk about the engineering controls of the biosafety cabinet. Additionally, another containment device that is used a lot for this are our centrifuge containment devices. So these are going to be centrifuges that have sealed rotors, that have an O-ring or a gasket that will actually seal that rotor, or containment cups or other types of containment devices. So I want to go ahead and do a quick discussion of best practices for working in a biosafety cabinet. I know a lot of people on here already work with human specimens and BSL-2 and things like that, but I think it's a good idea to go ahead and just reiterate these and go through this. So one thing you want to do is check to make sure that your BSc is certified. BSc certification, just in case anyone is wondering, we've had some questions about this. BSc certification is considered an essential service. So our contractors who do that service for our campus are still coming to campus and still taking care of that for us. Do not use your biosafety cabinet if any of the alarms are activated. Those need to be immediately addressed. Only one person should work in a biosafety cabinet at a time. They are not designed for multiple individuals to work in them at a time. Any use of hazardous chemicals, radioactive isotopes, or open flame is strictly prohibited. If you have a procedure that you think would need to use any of these things, you need to contact me directly, and we can talk about how to do that or what accommodations we can make. Also, please don't use your biosafety cabinet as a storage area. One of the things that we'll talk about as being very important is decontamination of work surfaces. You can't really do that if you're storing material continuously in your biosafety cabinet. Also, any overloading of the biosafety cabinet with unnecessary items can affect airflow and therefore the biosafety cabinet's containment. We suggest that you turn the biosafety cabinet on for a period of time before and after your work, just to allow some air to pass over the work surface and through the work area. We suggest doing that by turning the blower on 15 minutes before you begin work and allowing it to remain 15 minutes after you've decontaminated and finished work. Wear proper PPE when using the biosafety cabinet. So your personal protective equipment for this would consist at a minimum of a lab coat, eye protection, and gloves. Complete surface decontamination is required. And we'll talk about what efficacious disinfectants there are for working with COVID-19 patient specimens. And always work with the sash at the correct height. That is the height that the cabinet functions at, and anything above or below that doesn't provide the same airflow. One of the things that we always recommend to people who work in a biosafety cabinet is to plan their work before starting, so that you either have all of the items that you will need inside the biosafety cabinet, or you have them adjacent to the biosafety cabinet so that they are easily accessible and you don't have to continually move your hands inside and outside of the cabinet and move around. It is recommended that you set up your workspace in the biosafety cabinet to move from clean to dirty. So basically you have your clean supplies and new materials on one side of the cabinet, your waste container and disinfectant on the other side, and that way you move through the cabinet without potentially contaminating new materials and new media and that kind of thing. Work within the safety area, the biological safety cabinet, so you do not want to obstruct any of the grills that are at the front or the back of the work zone, and you want to work as deeply in the cabinet as you can comfortably. Now, don't stretch your arms so that you're unwieldy and uncomfortable in there, but work well inside the cabinet. Don't work near the front of the cabinet. Work in a controlled and steady manner. Move your arms straight in and out of the biosafety cabinet to avoid pulling large amounts of air out with you. Be aware that if you have a lot of, and hopefully nobody has a lot of human traffic behind the BSc right now, just because, well, hopefully you're not around a lot of human traffic right now. But know that anything that disrupts airflow can compromise the containment of the biosafety cabinet. Disinfect all materials that are removed from the biosafety cabinet, whether this is the outside of bags of waste that you're pulling out or materials that you will reuse or equipment. It needs to be wiped down before you remove it from the biosafety cabinet. We currently conduct our biosafety cabinet training as in person, so I didn't think anybody would be calling us up to really request that right now, but there is a wonderful link that the CDC has if you would like some additional training on working in a biosafety cabinet. If this is something new to you or you haven't done it in a while, the CDC has some on-demand training for that that's really good. The other containment device that we want to talk about, because you may by necessity have to centrifuge specimens prior to the inactivation protocol. It's important When you centrifuge things, to follow all the best practices. We know from experience with different agents that laboratory-acquired infections can occur from aerosols that are generated by improper centrifugation practices. So this is a very important aspect that we like to touch on. We recommend that you use screw cap tubes and do not overfill them, and nothing should be spun without a capped tube. Wipe the outside of tubes with disinfectant prior to loading them into your safety cups or your rotors. And if you're removing tubes directly from the biosafety cabinet to go to the freezer or something like that, those need to be wiped down before removal from the biosafety cabinet as well. Place all your tubes in sealed buckets or sealed rotors when you're centrifuging anything that's potentially infectious, and periodically inspect the gaskets and seals on those to make sure that they're in good condition. Sealed rotors and buckets should be loaded and unloaded in a biosafety cabinet and disinfected prior to removal. So if you have a centrifuge rotor that is a small one, or you have small buckets, you just take that right to the biosafety cabinet, load it up in there, seal it up, wipe it down, and then walk it back to the centrifuge. Ensure that your load is balanced, of course, and disinfect your centrifuge on a regular basis. Again, CDC has some good training for this if anybody would like some additional training at this point. As far as personal protective equipment, we're working in a biosafety cabinet, so we're really relying on that primary containment as the way that we manage exposure to these materials. Your personal protective equipment is a backup to that. So we recommend when you're working in the biosafety cabinet that you wear a lab coat or a disposable gown, disposable gloves, and eye protection or a face shield. All disposable PPE should be placed in the solid biohazard waste for processing. Any reusable PPE should be surface decontaminated, and lab coats can be laundered by your normal departmental procedure, whether that's using a laundry service or if you have laundry facilities in your department. Most important thing is they cannot be taken home for laundering. So decontamination of work surface is pretty important because we don't want anyone exposed to virus that could potentially be on material from these patient specimens. The good news is SARS-CoV-2 is easy to kill on surfaces with common disinfectants. If you want a full list of all of the EPA registered disinfectants that have been proven to be efficacious for SARS-CoV-2, the EPA has that on their website. And just for your curiosity and household use, all of the Clorox and Lysol wipes are on there. So if you can get them, they work. But all the things that you normally have in your lab work very well too. 10% bleach and 70% ethanol is what we usually recommend for biosafety cabinet decontamination, and it works just fine. But remember that clean surfaces are most effectively decontaminated. So if you have gross contamination, you may need to put a cleaning step in before you do your surface disinfection. This is from the EPA. The only reason I really wanted to put this up there, these are important things, you know, make sure that you read the directions and follow contact time and all of those things. But it also has locked them up to keep them out of reach of children. I would say, and this is something people have asked too, I hope that you don't have any children in your lab. But importantly, when you're doing this work, even especially at this time, but limit the individuals who are in the laboratory when you're working with these specimens. Waste disposal, right now, the COVID-19 positive patient specimens can be managed as normal biohazardous waste. And so standard UK protocols apply. If you have any questions about these, there's a lot of information about this on our website. But briefly, our standard practices are solid biohazardous waste is autoclaved and then thrown in the regular trash. Liquid biohazardous waste is inactivated generally by adding bleach to a final concentration of 10% and allowing 20 to 30 minutes contact time before disposal. Sharps waste should be collected in Sharps containers, and those are picked up per standard by your building, either through our e-track system or by custodial staff. So as far as the Biosafety Committee goes, all labs receiving COVID-19 positive patient specimens must have approval. This is not a lengthy process, but it does have to be done and it does have to be documented. If your lab currently has approval for human source material, we are asking that you submit an amendment to that protocol for many reasons, but the handling of these samples is slightly different than what we recommend for normal human source material. Additionally, we need to keep track of what labs possess these materials. Our registration information is available on our website, and you can always email us if you have questions about amending your protocol. One other thing that we need to be cognizant of when working with these COVID-19 positive patient specimens is that currently SARS-CoV-1 is listed as a select agent by the Federal Select Agent Program. SARS-CoV-2 is not, because it's new. But we presume that as the Federal Select Agent Program gains more information and as the current outbreak becomes more controlled, regulations may be imposed that require registration for any positive materials. This, if you're not familiar with Select Agent registration, requires strict controls for possession, use, and transfer. It includes background checks of personnel working with the material, security and containment measures, and the use of a BSL-3 facility. So registration, if SARS-CoV-2 becomes listed as a select agent, would be for labs not only working with live virus, but also with positive patient samples and any nucleic acid material capable of generating the virus. If registration becomes necessary, I think that we'll have quite a bit more notice, but the rule under the Federal Select Agent Program is that if a patient specimen is identified, positively identified to contain a select agent, all the materials related to that have to be destroyed or transferred to a registered entity within 7 days of the patient's release from a medical facility. That being said, I don't think we're near the control point on the current outbreak, and this would require a change in federal regulations. So I think we have a minute, but we're recommending that the best practices for labs receiving COVID-19 positive patient samples are to keep an active inventory of what you receive in your laboratory. If you have sample material that remains after the analysis that you do, it's suggested that if you don't need them, you go ahead and inactivate and discard unused portions rather than storing them long-term. If you need to store these specimens long-term, ensure that all the vials are marked clearly with the agent name and stored separately from other samples so that they could be easily located and accounted for in the event that we need to destroy or transfer those specimens. I've got a long list of references here and throughout the presentation just because, well, one, it's easy to include all the references because we don't have a lot of information at this point, but these are what we are working from. So if you have any questions about that, you can find these and look through them yourself. Here's my contact information. Like I said, if you have any experimental protocols or any situations that you feel like fall outside of what I discussed today, I would encourage you to contact me directly, or if you work with other staff in my office, contact them directly so that we can really look closely at what you're proposing to do and determine what is needed for that. Let's see. With that, I'm going to attempt to look at the questions and answer some of those, see if we have any. Let's see. Do you consider 56 degrees Celsius for 1 hour sufficient for inactivation of serum? Yes, From what I have seen, as far as what's recommended for SARS-CoV-2 and data for SARS-CoV-1, we expect that that is adequate for serum, especially based on the fact that with SARS-CoV-2, it doesn't seem like there is a high viral load in blood. So that is considered adequate. I think that's the only question that I have at this point. Okay. I might need a little more clarification on this question that just came in. How about FFPE tissues? Could you give us more information regarding manipulation and storage? Is that fresh frozen? Do you want to give me what the acronym is? I'm not familiar. Formalin fixed paraffin embedded. Thank you. That should be able to be worked with in your standard BSL-2 facility. We would still like you to amend your IBC protocol or let us know that you're doing that work, just so we can keep track of that. But if the tissue is fixed with formaldehyde, that would be acceptable. So I have a question. I'm reviewing an application that involves use of a vector that expresses a CoV-2 protein in cell culture. No infectious vectors would be produced. Would this be BL2 or enhanced BL2? Generally, that would be BSL2. Our IBC has also reviewed a protocol for a vector that expresses the spike protein of CoV-2, and that work will be done in cell culture, and that was approved at biosafety level 2. In the future, are all human samples requiring heat inactivation? No. We are only requiring inactivation for human specimens that, in this case, COVID-19 positive human specimens that need to have some manipulation done outside of the biosafety cabinet. They have to be inactivated prior to that. You can still work with them not inactivated in the biosafety cabinet. And our general human samples, we would expect we would continue with our normal practices. We have had some question about prevalence of COVID-19 people or SARS-CoV-2 positive individuals in the community, and would we change our human specimens handling based on that? At UK, we're pretty strict about using universal precautions and treating all human samples as infectious, so we would stand with our standard procedure for that. Okay, our lab is working with plasma samples. If we were to collaborate with other labs and other institutions, what is the protocol limitations regarding shipping transportation? If you have known positive patient samples, they have to be shipped as infectious materials. They cannot be shipped as category B. They have to be shipped as category A infectious agents. If you have samples that are not confirmed positive, they would ship via the normal category B. My hesitation in talking about shipping and transportation and transfer is that in the event that regulatory status changes, we really don't want a lot of our positive patient specimens to become someone else's select agent problem. So I would limit that work, or I would ask them if they are going to be storing specimens after use in the assay, that kind of thing. But generally, it should be fine. If you don't have someone in your laboratory who has current DOT IATA training for shipping of infectious materials, that should be conducted prior to doing any of that. So I have a question about activation of cells for a period of time prior to analysis. And I've gotten some variant of this question many different times in the past few weeks. And at this time, what I consulted with some of my other BSO colleagues, and really at this point in time, we are saying that there's no manipulation of that type that we are allowing. We really work with these positive patient specimens should be to get them in the lab, get them inactivated, and do analysis with them. Unfortunately, that's really all that our facilities safely allow for. Does the CDC issue standard procedure about how to inactivate different samples from humans? That would be very convenient, wouldn't it? But no, there is really no standard protocol issued for inactivation of different sample types. What I would recommend is if you have a sample type, well, we know very well, serum is pretty well documented at this point that the 56 degrees for an hour is adequate. I believe actually there may be a paper from SARS-CoV-1 that shows you can inactivate with a little shorter period of time. But what I would recommend, either contact us and tell us what type of specimen that you're looking at, and we can help do some research on that. I would also recommend doing a literature search and looking at sample type. If there's not data with SARS-CoV-2, look at if there is data for SARS-CoV-1. There are a lot of inactivation protocols out there for SARS-CoV-1 because it is a select agent, and they have to document and verify all of their inactivation protocols a little more strictly at biosafety level 3 and for select agents. So there's a lot of good information out there, but there isn't like a standard document from CDC or any other authority that really details all of that. Okay. This is a good question. I got this question the other day also. If we get blood from recovered COVID-2 patients, do we need to do another test to confirm they are negative before we consider them negative? Yes. And I think that this is a good way to look at this, because especially if we're trying to study, I know a lot of people are looking at immune response and immune function related to infection with this virus. If you can get a negative test and get samples that are subsequent to that negative test, then that takes a lot of the burden of all of these requirements off, and you could do more of the type of things that the stimulation and the things like that are kind of interesting and need to be done. If you can confirm that those samples are negative, then that would be appropriate. Once research opens back up, research teams from multiple areas will be collecting specimens. Should investigators obtain COVID-19 testing prior to enrolling a patient? How do we know our specimens contain the virus? So I will say two things on that. One, I defer to Helen and ORI and the IRB for recommendations on testing of enrollees in clinical trials. Second, I would say that it hasn't been suggested that we treat all human specimens kind of globally as being potentially positive for COVID-19 or for SARS-CoV-2. So in that regard, our recommendation for general human specimen work would not change. As far as the nuance and the specifics on whether you should test patients prior to enrolling, or patients that are on a clinical trial and that kind of thing. I think you're going to see a lot of guidance on that come out of ORI, so I will defer to them.
So if we don't have any more questions, I want to thank Brandy for coming today and presenting this really important information. She will be available through her office to answer any other questions that you may have. I see we have one last question that just came in, so I will let her jump in there and answer that question. And again, we will be posting this video on our website if any of you want to refer back to it for any of the guidelines that she has posted, as well as links to protocols at the CDC.
Okay, so there was one more question about sending slides. If they are fixed, then not an issue. Again, if you're shipping unfixed material that we know is positive, that's going to ship as an infectious agent rather than as category B. All right. Thank you all so much. And again, please reach out to me or to my department if you have any other specific questions. Thanks.